This is Unit 7, Part 2. We're now going to talk about the physiological function and regulation of the vascular system, the vascular part of the cardiovascular system. The volume of flow can vary through a particular blood vessel or a particular organ, but in the entire circulation it would vary with the varying cardiac output. It's measured in blood flow is measured in milliliters per minute. I think I'm going to change the second here. Okay. Blood flow is measured in milliliters per minute. It's for the entire vascular system, it's equal to cardiac output. Cardiac output is steady and constant, essentially constant if a person is at rest, but as soon as they start being active, the cardiac output goes up. I remind you that cardiac output is equal to the heart rate, okay, the rate of the heart beating, times the stroke volume, the volume that the heart puts out. So this is beats per minute and volume per beat, giving you a volume per minute of cardiac output. It can flow, remember, can vary quite widely through individual organs according to the physiological needs of that organ. For example, skeletal muscle, the flow can go up a lot when the muscle gets active. Skin, if it's cold, the flow can drop. If it's hot, the flow can go up a lot to send more blood to the surface of the body, so you radiate it away from you. Flow can increase tremendously into the abdominal organs when you after a meal, etc. There's many variations. We'll go through some of them. Okay, so now in terms of blood pressure, you know, the pressure in a blood vessel is really the force per unit area, the force on the wall of the vessel pushing outwards. It's typically expressed in millimeters of mercury. We don't talk about the units quite usually, you know, it's like 80 over 120, where the first number is the or 120 over 80, where the first number is systolic and the second lower number is diastolic. It's measured in larger arteries that are near the heart, typically the I think it's the brachial artery in the upper arm. And like all fluids, the same goes for gases actually, movement is from an area of high pressure to an area of lower pressure. So the driving force is the pressure gradient, the difference between a high pressure area and a low pressure area that will drive the fluid forward towards that lower pressure area. It's the driving force that keeps the blood moving. The resistance is an important concept to understand. It's the opposition to flow, usually because of the friction that the blood experiences as it flows through that blood vessel. And for blood circulation, it's referred to in general as peripheral resistance. There are three important sources of resistance in the blood vasculature, in the blood vessels. One is the thickness of the blood itself. The other is the total length of the blood vessels, and the third is the blood vessel diameter. Now, the things that are typically reasonably quite constant are the blood viscosity and the blood vessel length. But what can change, and can change quite rapidly at times in different areas, is the diameter of a blood vessel. It can be significantly altered by vasoconstriction or vasodilation. Constriction is when the smooth muscle around the blood vessel contracts, and so the lumen, the space inside the blood vessel, gets narrower, the radius is reduced. And the relationship between the blood vessel radius and the resistance is that resistance goes up as the radius gets smaller. Okay, so it's an inverse relationship. The larger the radius, the lower the resistance to blood flow, and the smaller the radius, the higher the resistance, which you probably intuitively understand. I hope that if you squeeze a water hose tighter at one spot, then there's less flow through the hose because you're reducing the radius of the hose. The same goes for blood vessels. And the relationship is that resistance is equal to 1 over the fourth power of the radius. Just as an example, if the radius is doubled because of this 1 over 4 relationship, the resistance is reduced by a factor of 16, so it's only 1/16 if the radius gets doubled. So it's a very responsive system. Small diameter arterioles in the blood vasculature are in fact the major determining factors to the overall peripheral resistance. One of the pathological problems that's encountered, particularly with age, is deposits of what are called fatty plaques due to atherosclerosis. Deposits of material along the wall of the blood vessel, and actually often accompanied by hardening the blood vessel, even some calcium deposits can occur. These cause turbulent blood flow, so that when you have a blood vessel, normally what you have is laminar flow of the blood through the vessel. It's flowing in smooth layers through the blood vessel, but with deposits along the side or any obstruction, partial obstruction, what you get is turbulent flow, so that it's not smooth anymore, and that turbulence that you can get in the flow can cause dramatic increased resistance. And also, of course, the obstruction not only can increase the turbulence, but also narrow overall and cause a narrowing. This kind of turbulent flow occurs with, and I didn't show it, but if you have some sort of deposit of fat along the side, I didn't really draw it properly here. If you have some sort of deposit of fat, then you get turbulent flow. So the flow actually goes like that before it carries on. Flow is the key function that you want in the blood circulation. It's directly proportional to the differences in pressure. Flow will always go from high pressure to low pressure. If the pressure in one area minus the pressure in another is increased, the delta P, the difference between the two, then blood flow speeds up. If the difference is smaller, if there's less of a gradient, a change, a difference in pressure, then blood flow will decline. So the key relationships are that blood flow is inversely, I'm going to change the color, is inversely proportional to resistance. The higher the resistance, the lower the flow. So higher resistance, lower flow, and if resistance is decreased, then flow increases. And delta P is directly proportional, but the resistance is the key, more important factor. So flow, or F, is equal to delta P over R, where delta P is directly, flow is directly proportional to the pressure gradient and indirectly proportional to resistance. And of course, resistance is mostly determined by the radius. So when we look overall at the overall vasculature, we have the heart generating flow by generating a higher pressure area as it contracts and pumps the blood out, and the blood will move along the pressure gradient from higher to lower pressure. And that flow is affected by how much resistance it meets, resistance to flow. The systemic pressure overall is highest in the aorta, right after the heart, where the most pressure is generated. And then it declines as you move along the length of the blood vasculature until you finally get to the blood returning to the right atrium of the heart, where the blood pressure is essentially zero. The biggest change in blood pressure from within one particular area of the vasculature occurs within the arterioles. As it flows through the arterioles, you get the steepest drop or change in blood pressure. And here you see the, anatomically, the going from the largest vessels on the arterial side to the arteries to the arterioles till you finally get into the capillaries. And then those lead to the venules, veins, and vena cava. In terms of blood pressure, you have on the arterial side, at least down to the medium, smaller size arterioles, not in the very smallest, but you do have a clear difference between systolic and diastolic. So it's a pulsing pressure, right? There's a pulse which you can feel at your wrist if you touch the pulse. In fact, is that bulging out and then relaxing and bulging out again, which comes with each heartbeat and pressure wave as it passes through. But once you get down to the smaller arterioles, that disappears, that pulsatile flow disappears, it's smoother flow. But in terms of the biggest drop from the beginning of a part of the vasculature inside that area, it's in the arterioles that you get the biggest change in terms of a drop in pressure. Okay, arterial blood pressure in fact reflects two factors when you're looking at arteries closer to the heart: their amount of elasticity, and just like with the lungs and respiratory physiology, physiologists like to talk about compliance, the ease with which you get expansion. Compliance in the lungs is how easy it is to expand your lungs, to fill them up. And here compliance can also apply, how easily the blood vessel distends or stretches out. And that reflects their degree of elasticity. The amount of blood forced into them at any given amount of time and during any given time is another factor that determines the arterial blood pressure, their elasticity and how much blood is being pushed into them. So blood pressure in the elastic arteries near the heart, again, as you know, is pulsatile. Systolic versus diastolic is up and down, not down to zero, but drops. When the heart relaxes, you get a drop. Systolic pressure gets exerted on the arterial walls during ventricular contraction, left ventricular contraction for the systemic circulation, and then it's lowest during ventricular cycle. I don't know what cycle. Relaxation. Lowest arterial diastolic is a lower arterial pressure during the ventricular relaxation. I don't know why it says cycle. It's a mistake. Relaxation. Okay, that's when the heart relaxes. After it contracts during systole, it relaxes during diastole. The difference between the two is the pulse pressure. Pulse pressure is the difference between systolic and diastolic pressures. Now that's, typically we do talk about blood pressure in terms of systolic and diastolic, 120 over 80. But overall, I'd say the most important physiological measure of how well blood will flow through tissues is given by the mean arterial pressure, the average arterial pressure. And that is equal to the diastolic pressure plus 1/3 pulse pressure. And if you're looking at a average person, young, healthy person at rest, a young adult should have a systolic of 120 over 80. And 120 systolic, I'm going to change that. Just a second. So typically you would have 120 systolic and 80 diastolic, giving you, while we're here, I might as well calculate, giving you a pulse pressure of 40. And so mean arterial pressure is diastolic 40 plus 1/3 of the pulse pressure, so 40 divided by 3. I can tell you that 40 divided by 3 is 10.33, so mean arterial pressure of 50.3. Let's go with 50 and leave the 0.3 out of it. It's not that significant. Mean arterial pressure of 50 is normal or mean arterial pressure, and that's, when you measure mean arterial pressure, that's a better idea of how well blood will flow into a particular tissue. Are you getting enough pressure to supply that area of the body? In the capillaries, the pressure is quite low. It's only 20 to 40. Remember, it's no longer pulsatile. There's no higher systolic and lower diastolic. It may range, but it's 20 to 40. Anything higher could, in fact, rupture the capillary. So it's a fairly low blood pressure, slower flow often. It's enough to force the blood through the capillary bed, and you can also get enough to so that you get distribution and diffusion of nutrients, gases, and hormones between the blood and the tissue. And by the way, as you'll see soon, some fluid gets pushed out into the tissues at the beginning of the capillary beds. When you move to the venous side of the circulation, the venous blood pressure is steady. There is no pulsatile nature, no higher systolic and lower diastolic. The pressure gradient is only about 20. That's between the venous side and the left atrium. So you only have a pressure gradient on the venous side. From the end of the venous side is the right atrium. So you only have and it's 0 there, so it's about 20 on the venous side, and it goes to 0. That's why if you cut a vein, you get even blood flow, whereas if you cut an artery, you'll get spurting. Luckily, as an evolutionarily defense design and advantage and survival, our arteries are buried deeper than the veins. The veins, not all of them, but many of them tend to be closer to the surface than arteries. So if you do get cut, typically it's a vein. The things that help, despite that low pressure gradient driving blood back to the heart, despite the fact it's only 20, the blood does have certain characteristics on the venous side, or the venous side of the circulation has certain characteristics that help move the blood along and give adequate venous return to the heart. Blood flowing back to the heart is called venous return, and the blood pressure on that side is the venous blood pressure. Venous blood pressure, the higher the venous blood pressure, the higher the gradient. I mean, there's not much, right? But it helps maintain flow back. Pressure is locally increased somewhat, or not so much increased as, increased somewhat, and also maintained, I would say, by two things. One is the respiratory pump, and the other is the muscular pump. So these help with venous blood return to the heart, venous return to the heart. Pressure changes are created as you breathe, and helps move blood closer towards the heart. You have squeezing of the local veins helping push blood to the heart as you breathe, and also skeletal muscle contraction will help push the blood forward. Remember that if you squeeze a vein, the blood inside the vein can only go in one direction because there are valves at regular intervals along the vein that prevent backflow. So it can only move in one direction. When you squeeze it, it'll move forward due to the venous valves. And here you see an example. I don't know how, it's a bit ridiculous to have two muscles that are so huge. You have muscle around the veins, skeletal muscle, the vein goes through it. They should have really shown one muscle here, but anyhow, when you contract that muscle, it will squeeze on the veins, and because the valves only open in one direction, flow goes towards the heart. So we have this respiratory pump and musculoskeletal pump helping move blood forward. Overall, the maintenance of blood pressure requires good interaction between the heart, the blood vessels, and the kidneys. Kidneys, after all, are filtering the blood, and if you have increased volume, you will put it out in the kidneys. If you have decreased, then the amount of output of fluid by the kidneys is reduced. It's all supervised by the central nervous system. The main factors that influence blood pressure are, in fact, cardiac output, peripheral resistance, and the overall blood volume. So blood pressure, in fact, is equal to cardiac output times peripheral resistance, and will vary directly with cardiac output, peripheral resistance, and blood volume. Your blood pressure goes up if your cardiac output goes up. There are examples of cardiac output going up. Well, if cardiac output is equal to heart rate times stroke volume, and you start suddenly exercising or any type of skeletal muscle activity, then your heart rate rises because the sympathetic nervous system triggers that. So there's heart rate times stroke volume. The other thing is that the contractility of the heart, remember, can increase with increased sympathetic nervous system stimulation. So the heart contracts harder and squeezes out more. So stroke volume will also go up somewhat. So you can get increases in cardiac output with exercise. Peripheral resistance, you can get an increase in blood pressure due to contraction of the vasoconstriction of the overall systemic circulation. If you have a higher overall blood volume, then you will also have a higher BP. But in general, BP is equal to cardiac output times peripheral resistance. Okay, so in terms of cardiac output, and again, cardiac output is equal to heart rate times stroke volume. Heart rate is per minute, and stroke volume is the volume of blood that the heart puts out on each beat, on a particular beat. Cardiac output is very much determined by the return of blood to the heart. It pumps the blood that comes back to it. So venous return is something to certainly consider. And also neural, central nervous system controls and hormonal controls. Resting heart rate, in fact, is controlled in terms of neural control by what's called a cardioinhibitory center in the brain stem. And signals from there go out via the vagus nerves. The stroke volume is in fact controlled by venous return. The more blood returning to the heart will have an effect on how much blood the heart can pump out. I'm not sure exactly why I have this term here, but it's important for you to understand that when the heart, yes, here you go. When the heart is relaxing, it's filling, and it's the blood that it's filling with is the venous return back to the heart, the blood flowing back into the heart. So once it's finished filling, it reaches its end diastolic volume, the volume at the end of relaxation of the heart where the heart is filled, and that's EDV, end diastolic volume. When the heart, and we've talked about this earlier when we did the cardiac physiology. So end diastolic volume is the volume at the end of the filling of the heart during diastole, and then the heart contracts, and then the end of systole is the end systolic volume. The end of systole is at the end of contraction, so that's the point at which it has pumped out that blood that it filled with. So the difference between end diastolic volume and end systolic volume is in fact the stroke volume. And a big factor in determining how much the heart holds is how much venous return there is. If the person is under some stress, some sort of trigger, the cardioacceleratory center in the brain stem will increase the heart rate, and also you'll get an increase in stroke volume. The reason the stroke volume increases is because the end systolic volume is reduced. The heart will contract harder. And as a result of that increased output, the stroke volume goes up, and mean arterial pressure will increase. And that's the kind of response you do want when you're triggered by something that upregulates, triggers the sympathetic nervous system. You'll get an increased output nervous from the cardioacceleratory center of the brainstem, causing an increased heart rate and stroke volume. Okay. This is a flow chart describing and looking at that kind, and we may have done something before similarly when we did cardiac physiology. And just to remind you, this does involve the vasculature, particularly venous return. This is the response in terms of cardiac output, what effects on cardiac output if the blood pressure drops. If the blood pressure drops, that will trigger the cardiac centers in the medulla. The medulla is within the brainstem. This whole area here is the brainstem. So that's where the cardioacceleratory and cardioinhibitory centers are. Brainstem centers they're cardiac centers affecting the function of the heart. So a drop in blood pressure will activate these centers in the brainstem, in the medulla, and you get an increased output of the sympathetic activity, so that rises, and a decrease in parasympathetic activity. Again, I would remind you that there are two divisions to the autonomic nervous system, ANS. The autonomic nervous system controls involuntary tissues like the cardiac muscle or the muscle in the blood vessels, around the smooth muscle in the wall of blood vessels. It has two divisions, the sympathetic and the parasympathetic division. And with activation, fight and flight kind of stimulation, you get upregulation of the sympathetic division of the autonomic nervous system and downregulation of the parasympathetic. If you have increased sympathetic activity, neural output of the sympathetic division of the autonomic nervous system, you will get a number of things, including increased cardiac muscle contractility, which will cause a decrease in end systolic volume, right? The volume of blood left in the heart at the end of each contraction, if it's contracting harder, right, increased contractility, then end systolic volume goes down. Stroke volume is end diastolic minus end systolic. If end systolic goes down, then stroke volume goes up. That also makes common sense, right? Because if you increase the contractility of the heart, not only are you decreasing the amount of blood left in the heart at the end of systole, but you're increasing the amount it puts out, right? So stroke volume goes up. The other thing that happens with increased sympathetic activity is you get release of epinephrine into the blood. Epinephrine and adrenaline are the same neurotransmitter. That also causes increased contractility of the heart muscle and the associated, effects there. And it also causes an increase in heart rate. Adrenaline or epinephrine will cause you to have a faster heart rate. Now, that epinephrine in the blood comes from the adrenal glands, but increased sympathetic activity also directly will cause heart rate to go up. And so you have an increase in heart rate. The fact that parasympathetic goes down, parasympathetic output slows the heart rate. So if that is decreased, that kind of effect of the central nervous system is inhibited, then that also contributes to an increase in heart rate. In the end, an increase in stroke volume and an increase in heart rate will both cause an increase in cardiac output, because cardiac output is equal to stroke volume times heart rate. In terms of the vasculature, you have, with activity, an increase in respiratory activity, and therefore that causes more blood to return to the heart, because it helps venous return. And your increased activity causes you're going to be using your skeletal muscles, so the muscular pump, not just the respiratory pump, but the muscular pump starts working more, so you get an increase in venous return. The increased venous return is what determines how much the heart fills at the end of diastole, so an increase in end diastolic volume. That directly causes an increase in stroke volume. So here, this area here, I'm going to outline it. That all has to do with vasculature effects on changing of cardiac output. And that's the end of Unit 7, Part 2.